All right, so let's take a look at the chapter 34, which is pediatric emergencies. So pediatric patients differ anatomically, physically, and emotionally from adults. So they are not just small or tiny versions of adults. You do want to make sure that you understand what's normal, what's abnormal for them, what's going to vary based off of their age and their developmental levels. Fear and pain can make them difficult to assess, so you need to gain their trust and know how to talk to them. Once you've learned how to approach children of different ages and what to expect while caring for them, you'll find that treating the pediatric patient also offers some very special rewards. This can be some of the best calls of your career, where you really feel like you're making a difference with that patient. So communication with the patient and the family. When you're caring for an infant or child, you need to care for the parents and caregivers as well. So providing them with emotional support and reassurance, trying to keep them as calm as possible. If the parent is agitated, the child is going to pick up on that and will almost always react the same way. So we want to try to remain calm, efficient, professional, sensitive, empathetic, and again, giving good information to them. Looking at growth and development, it's important that you know what these age ranges are, and we're going to break that down in just a second and talk about some specifics for each one. But talking about the differences between an infant, toddler, preschool age, school age, and an adolescent. So the infant actually is broken down into several different stages just simply because of the developments that happen in that first year of life. So the first month after the birth is neonatal or newborn period. So that first month you might call them a neonate or a newborn rather than just an infant. During those first 2 months, they spend most of their time sleeping and eating, and they cannot tell the difference between parents and strangers, so they don't get scared, they don't care who's holding them, they don't have stranger danger. Crying is one of their main modes of expression. They don't really have any other way to communicate and let you know, but inconsolability could be a sign of significant illness. So even if they are crying, they should be able to be consoled in some way for it to be normal. At 2 to 6 months, persistent crying, irritability, or lack of eye contact could be an indicator of a serious illness, depressed mental status, or a delay in development. So they should be reaching some of those milestones by this point. At 6 to 12 months, they start to have that separation anxiety, so they might be start crying or get upset if they're separated from their parents or normal caregivers. And persistent crying or irritability, again, symptoms of a more serious illness. During your assessment, you want to observe from a distance at first and have the caregiver holding the baby during the physical assessment and provide sensory comfort. So if you can let them have a stuffed animal or a blanket with them, try not to have any bright lights or loud sounds on. Do painful procedures at the end of the assessment so that you get everything you need done. If you have children or have ever seen children who go to the pediatrician's office to get their vaccines, they always do that very last, right before you leave. Right? They want to do their full assessment first so that they're still somewhat cooperative. We want to complete each procedure efficiently and avoid interruptions, and explain each procedure to the parent or caregiver before you perform it, what you're doing and why you're doing it. Moving into the toddler stage, this is from about the first year up to 3 years old, and this child is considered a toddler, and they have rapid changes in their growth and development as well. So from 12 to 18 months, they are usually exploring, and they're not afraid of injuries. They may not be able to fully chew their food, which could lead to an increased risk of choking. At 18 to 24 months, they may cling to parents or a comforting toy, again, that separation anxiety. So they may have stranger anxiety, again, resisting separation from the caregiver. They usually have a hard time describing pain specifically. They might say something hurts, but be hard-pressed to get any details out of them about it. They can easily be distracted, so that's a good thing. You can distract them with a toy or with a cell phone, watching YouTube, honestly, anything that it takes to get them to relax and be comfortable. You want to begin your assessment here at the feet as you're gaining the child's trust, so you can work up. Unless it's a life-threatening situation, then of course you would start at the head like normal. Persistent crying, again, symptom of a more serious injury or illness. At 3 to 6 years old, these are the preschool age children. and they are at higher risk for foreign body airway obstruction still. Even though they can probably chew their food, they're still putting stuff in their mouth and coming into contact with small objects all the time. They can understand directions, and they can be a little bit more specific in describing their painful areas. Much history will still be obtained from the caregivers or parents, and we want to communicate with them very simply and directly, give them very simple instructions. Appealing to the child's imagination can facilitate the exam. So a lot of times they want to help with the exam. They want to help, ask, can you help me listen to mommy's lung sounds? And then we'll listen to yours. Whatever it takes, again, incorporating that parent or caregiver as you see fit into your assessment. Never lie to this patient, but again, remember they can be easily distracted. Still starting at the feet and moving up towards the head, they are really receptive to Band-Aids. So using those Band-Aids to cover the site of an injection or other small wounds, you would be shocked at how much better they will feel with just a Band-Aid. Modesty is starting to develop, so try to keep them covered as much as possible, even if not for the child, for the parent's sake. At 6 to 12 years old, they are considered school age, and these children begin to understand death. They begin to act more like adults, so we start doing the assessment more like an adult. You can gain their trust by talking to them, not just the caregiver. They might be able to provide some of their medical history and information. They're probably familiar with the process of a physical exam by this point, so you can start at the head and move down to the feet. Try to give them choices that are relevant to the care. So rather than saying, would you rather not check your blood sugar, ask them, would you rather check your blood sugar or your blood pressure first? Things like that, so that they still feel like they have some type of choice. Ask questions, again, that will let you control the answer. Allow them to listen to their own heartbeat or anything that you feel is going to interest them in the back of the ambulance. Understand the difference between physical and emotional pain, so they can provide a little bit more information to you here as far as explanations about what is causing the pain. And you can explain to them what's happening within their body, and also what are you going to do and what might they do at the doctor's office to resolve it. At 13 to 18 years old, these are considered adolescents, so they are, again, very physically similar to adults, but they still might have the children's emotional status. This is a time of experimentation and risk-taking behaviors, which makes them really prone to accidents, thinking about drugs and alcohol, sporting accidents, just general, horseplay that can lead to accidents. They can often understand complex concepts and treatment options, and they really need to be involved in their own care. An EMT of the same gender should do the physical exam whenever possible. Allow them to speak openly and ask questions. Remember that these female patients in this age group could potentially be pregnant, and they have a very clear understanding of the purpose and meaning of pain. So don't be afraid to get down and dirty with the details of what's wrong. Looking at some anatomy and physiology, again, the body is very growing and changing rapidly during childhood, so you need to understand the physical differences between the pediatric patient and an adult and alter your patient care accordingly. One of those differences is going to be the respiratory system, so looking at the anatomy of airway, which differs from adults. The pediatric airway is smaller in diameter and shorter in length, so that trachea is fairly small. Remember, it's the size of your pinky finger, and so that's each person, so a child's pinky finger can be very small. Lungs are also going to be smaller. They might not be at full adult size capacity yet, and their heart does sit a little bit higher in the chest. Looking at these examples here of the adult versus the child, you can also see that the child's tongue is proportionally larger in the mouth than the adult's, and so that could be a potential airway obstruction as well. The glottic opening is higher and positioned more anteriorly, and the neck appears to be almost non-existent. As the child develops, this neck will become proportionally longer, and the vocal cords and epiglottis achieve anatomically correct adult positionings. The back of the head, the occiput, is very round. That can make that sniffing position kind of difficult, and if they're lying supine, actually cause the head to kind of lean down with chin to chest, obstructing the airway. So you might want to support underneath the neck with like a blanket or towel roll. Again, we mentioned the proportionally larger tongue. They have a more floppy U-shaped epiglottis. They have less developed rings of cartilage in the trachea, making it more pliable, which is good in some ways, but it's also bad because it's more susceptible to injury or collapse. And they have a narrowing funnel-shaped upper airway, so it actually comes down to a funnel rather than being completely straight like a adult airway. And again, same thing, diameter of the trachea is it's the size of a drinking straw for an infant. Everybody's is the size of their own pinky finger, roughly. So children have oxygen demand twice that of an adult, so they breathe a little bit faster. The smaller that they are, the faster that they breathe. Remember, once they get to about 8 to 10 years old, they start to be breathing about the same rate of adults, but very small children will be breathing quite a bit faster. The diaphragm muscles will dictate the amount of oxygen that's inspired, and your gastric distension can interfere with movement of the diaphragm and lead to hypoventilation. So we want to be very cautious that we are not, if we're ventilating with a BVM, that we are not seeing any gastric distension, and that we're trying to avoid that by getting a good seal and with proper head positioning. Also considering here that we're using properly sized equipment anytime that we are managing, so not just a BVM, but also any of your airway adjuncts, nasal cannula, non-rebreather, whatever it is, that it is the proper pediatric size. Looking at the circulatory system, we need to know the normal pulse ranges. An infant's heart can beat up to around 160 beats per minute or more. Children are able to compensate for decreased perfusion by constricting the blood vessels in their skin, which means that they can compensate quite a bit longer. And so we talked about this during shock, how a pediatric patient can compensate for quite a while before moving into decompensated shock. The signs of vasoconstriction, meaning that they're shunting that blood from the skin down to their vital organs, would be paleness or pallor, weak distal pulses in the extremity, delayed capillary refill, and cool hands and feet. So these are the normal pulse rates for the varying ages. So looking at newborn to 3 months, 85 to 205 is considered normal. 3 months to 2 years would be 100 to 190. 2 years to 10 years would be 60 to 140. And then again, after we get to about that 10-year-old range, they are similar to an adult, so around 60 to 100 beats per minute. Looking at the nervous system, the pediatric nervous system is immature, underdeveloped, and not very well protected. So the head-to-body ratio of the infant and young child is disproportionately larger, making that head very heavy and almost the center of gravity for these small children. So if they were to fall, most likely they're going to hit that head, which could be kind of dangerous for them. They have the smaller subarachnoid space, which leaves less cushioning for the brain, and the brain tissue and cerebral vasculature are very fragile and can be prone to bleeding from shearing, which are shaking back and forth or movement out of place. The pediatric brain requires a higher cerebral blood flow, oxygen, and glucose, so they are at risk for secondary brain damage from hypotension and hypoxic events. So we need to make sure that we are getting adequate blood flow, adequate oxygen supply, and adequate glucose. And again, children are even more sensitive to those changes than adults. The spinal cord injuries are a little less common, but if they are injured, it is more likely to be an injury to the ligaments because of a fall. If you have a suspected neck injury, we want to perform manual inline stabilization, just as we would for an adult patient. Looking at the gastrointestinal system, these abdominal muscles are a little less developed, which can decrease the amount of protection that we're given from trauma. So the liver, spleen, and kidneys are proportionally larger, situated more anteriorly, kind of close to one another, and they're very prone to bleeding and injury, unfortunately, due to that lack of protection. Looking at the musculoskeletal system, open growth plates allow the bones to grow, and that's very important. But as a result of those growth plates, the bones are softer and more flexible, which can make them more prone to stress fractures. So the bone length discrepancies can occur if injury to a growth plate occurs, which means that bone would essentially stop growing, making it shorter than that on the other side. So we want to be really cautious about that. The bones of an infant's head are flexible and soft. We call those fontanelles, those soft spots. And remember that those plates shift to allow the baby to pass through the vaginal canal, but over around their first year of life, those begin growing back together normally. And the thoracic cage is highly elastic and pliable, which again is good because it's going to be less amount of fractures happening inside of the ribs, but it also doesn't offer as much protection to the heart and the lungs when it's flexible like that, so that could be detrimental as well. I'm going to stop this portion of the video here. I will see you guys in part 2.